Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.
Good evening, ladies and gentlemen. Welcome to the 6th edition of the Ghanaian Community Awareness Forum. Today, we have a good topic as always, but exceptionally good topic to go through. We have extremely good panelists who are assembled here. As always, my name remains Emmanuel Kwesi, the chairman of Ghana Union, UK and Ireland. We have with us today panelists drawn from expertise over a number of years who know what they are talking about. And so I'm sure all of you will be very happy by the time you leave here with the knowledge you take away. And hopefully we can go out there and help others to help others who otherwise will not hear this information. Putting this program together has been with the help of the Ghana Nurses Association, the Nightingale Nurses Association, and the Western Regional Association of Nurses UK in partnership with Ghana Union. We also have the support of the Ghana High Commission in delivering these sessions to you, and in partnership with Omega Live TV. We've also found a new and some giveaways from a money transfer company called Express Pay, where you will get £10 if you send anything to Ghana to a family or friend. They will add £10 to it. So we thought, why not? Why don't we get you to show some love to somebody? So Express Pay will be featuring today, and along with any other one that will come from time to time. All we are doing is to find you the best deal as a community and help everybody as we go forward. Few rules that will apply today. As always, we will make sure that all audience are muted throughout the program, and except for speakers who have the right to unmute themselves when they're about to speak. During the Q&A sessions, audience will be enabled to unmute themselves, and where possible, please show your face or give us your name so we know who we are dealing with. There's no reason whatsoever why you should feel that you can't do that. And if you can't, it's also acceptable. All we need is that you give us your name. Please use the Zoom icon to raise your hand if you have any questions, and kindly go straight to the point. Where possible, one question at a time, so you can give room for others who otherwise also want to ask some questions to do so. We have with us today three panelists who will talk us through the topic of psychosis, insight into psychosis today. Our first panelist will be in no particular order, but our first panelist tonight will be Dr. Victor Doku. Dr. Doku is a UK-trained Ghanaian psychiatrist and epidemiologist. He's a consultant psychiatrist at Oxley's NHS Foundation Trust and an honorary senior lecturer in psychiatry at the Faculty of Health and Sciences and Medicine at King's College, London. He is an alumnus of the University of Ghana Medical School and London School of Hygiene and Tropical Medicine. He leads an international diasporan volunteering initiative on mental health educators, called Mental Health Educators in the Diaspora, a multidisciplinary faculty of diaspora mental health professionals that support pre-service and continuing professional education and training in mental health in Ghana and Nigeria. Welcome to the forum, Dr. Doku. Thank you very much. We also have Mrs. Victoria Edu Annan. Victoria is a registered senior mental health nurse practitioner with over 20 years experience working in mental health services. She is currently Deputy Operational Manager for Early Intervention Services, working with young adults between the ages of 18 and 35 years who have had a breakdown in their mental health for the first time. Victoria also, along with the pandemic, is a COVID vaccinator, a staff governor at the East London NHS Foundation Trust, a student placement lead, an assessor for the School of Nursing, and a lead interface personnel between her trust and outside agencies dealing with complaints and referrals. Victoria is also currently the Public Relations Officer for the Ghana Nurses Association UK. Victoria, welcome to the forum. And
Thank you.
Our next panelist will be Mrs. Rose Humbo. Mrs. Rose Humbo is currently a divisional lead mental health nurse with Oxford NHS Foundation. Rose has, in line of her profession, gained 25 years and more experience working across various NHS trusts, roles across the country in different pathways in mental health, specializing in urgent care pathways for children, adolescents, and older adults mental care. Rose is currently the chair lady of the Cameroonian Nurses Association in the United Kingdom. Welcome, Rose. Thank you for joining us.
Thank you.
And so at this point, we'll be going straight to our panelists to share with us what they have for us. Dr. Doku will be leading, and Dr. Doku will be taking us through the insights, the general overview of psychosis and insight into it, and we will lead on to other panelists who will have different areas to talk to us about. So, Dr. Doku, please take over from me. Thank you. Do we have Dr. Doku unmuted? Oh.
Hello, can you all hear me?
Yes, we can. Thank you.
Yes, thank you very much for this invitation. And I'd like to thank my colleagues in the mental health educators in the diaspora, and a few people need mention. It was Emma Madi who linked me up to these sessions, and I owe her a wealth of gratitude. And I'd like to thank colleagues who've supported our teaching initiatives, Eben Ofwebuache, Parkway Siotri, Stephen Kumi Yeboah, Mercy Brown, Vera Damte, Francis Ajinku, Maximilian Tego, Peter Pra, and a few others. What is psychosis? Next slide. So can you see is my slide shared? Or
Yes.
are my slides here?
We can see.
Oh, okay. So big topic. And I'm going to, the two other panelists will go a little bit into detail, but a few things that I'd like to share. There are no laboratory tests, and there are a variety of perspectives depending on your professional orientation, whether a psychologist, psychiatrists. The nurses are usually on our side in terms of doctors. The psychologists also take another position, but it's all good and gives us a healthy debate in terms of the various perspectives. And the next slide, I just want to emphasize, this is a saying in Ga, Omanfo Seke Ayomla. It has to do with the early recognition and detection or identification. And the saying is that if there's psychosis very close to you or within your surroundings, sometimes it's very difficult to detect quite early. People say that's how the person is, that's how they are, and the detection eludes or evades early detection. So there's a very narrow definition of psychosis, just hallucinations, having experiences in all the modalities of sensation without having the stimulus. People hear voices, they see things when there's really nothing about. They have sensations of touch and smell, and there's really nothing. And delusions are generally defined as abnormal beliefs which are fixed and held with a degree of conviction. If we just want to use the narrow definition of hallucinations and delusions, we'll be missing a lot. So there's a broader definition, which our colleagues, the rest of the panelists will be talking about. And then there are prodromal symptoms. When this thing is going to happen to you, how does it manifest? There's a usually running period of patchy symptoms and clinical signs, and eventually builds up to a full diagnosis. Initial stages, people might say you just have a depression, or you may have some somatic symptoms, etc. But then the full picture isn't built yet. The prodrome, building up to it. Then there are negative symptoms, and these are usually the deficit syndrome, a lack of motivation, poverty of speech, poverty of content of speech, apathy, active social withdrawal, and other things. Another set of symptoms are the cognitive symptoms, and especially things that affect people's working memory. People are not able to hold and multitask and do the cognitive level drops. Then the affective symptoms talk about mood symptoms, which go along. By far, the positive symptoms, things like hallucinations, delusions, excitement, those are the symptoms that people usually are familiar with. Because when people talk, people might be a bit hostile. Occasionally, people might be aggressive, chaotic, and this is what most people are taken up with. But to emphasize that even though the positive symptoms eclipse the other symptoms that herein mentioned are equally important. So is it possible to have psychosis without hallucinations and delusions? Well, it is, but the jury is out, and the other panelists would have time to talk about this. So my experience training in medical school, postgraduate training in Ghana, and coming over here and training here, and clinical experience in Northern Ireland and in London exposes me to a variety of cultures or subcultures. So the cultural factors are very important. They shape our beliefs, they shape our help seeking behavior, they affect our identification, treatment, the outcome, and our prognosis. And for people who cannot express themselves in English, or even if they did, there's a lot of prominence and persistence of bodily symptoms, the body somatic symptoms, which you remember in the previous talk, I did mention a number of somatic symptoms associated with anxiety and depression. And somatic preoccupation is very much prominent in psychosis. We also have to look at subculturally influenced ideas, things that people believe in their own subcultures, which they share. And then we also have to consider the idioms of expression of psychosis. When people have psychosis, how does it manifest, or how do they express? And people in areas where people are spiritual, they tend to, the expression includes lots of spiritual words and etc. In areas where people are not spiritual at all, the signs and symptoms refer to electromagnetic radiation and all sorts of things, which is relevant to their culture. You will recall that in the first presentation in May, I did refer to the biopsychosocial spiritual framework. And here, I'd like to emphasize that in Africa, or in West Africa, in Ghana in particular, we have our indigenous classification of diseases. And according to those in that classification, mental health is not recognized as amenable to Western Orthodox medicine. Traditional medicine takes precedence, and people go and check things out. Things that we will call bribism, if you pardon my fancy. So people have to check things out, and they go to other places at their first source of or course of or recourse. It's not to Orthodox Western medicine, and they may have faith healing. And even when they have seen Orthodox Western practitioners, like those of us who've trained here and gone back to Ghana, etc., they still interpret this as a spiritual attack and go ahead and pursue other modalities of treatment alongside Western Orthodox treatments. You will also recall I mentioned the patient evaluation grid. Why this disorder? Now, the bizarreness can be quite perplexing. And why me? Why this person? Why now? And why no recovery? This is a bit of revision and what we went over, but there are crucial questions that we need to address. Why this disorder? Why in this person? Why now? And why no recovery? Okay. And this grid, I've imported it from the last presentation. I forgive the font size, but on the left side is biological, social, psychological, psychodynamic, and then spiritual. And then the questions that I asked, which can be summarized into predisposing, precipitating, and perpetuating factors. Another thing that we must also consider is the pre-morbid personality. So in our cultures, we have something called usubai, or your characteristics. And the personality is the unique characteristics that make you different, that allows us to distinguish you from another person. Okay, so it's very important. So we know how, when this condition sets in, how people deviate or from what they are as a person, and then how, when they are recovering, they become it. And also there are some sort of personality adaptations or behaviors that may make you prone to certain things. Okay. I also want to mention the use of recreational drugs, the abundance of recreational drugs. Some recreational drugs are culturally sanctioned, alcohol, some are culturally prohibited, some are legally prohibited, and then we have in the UK, the new psychoactive substances. You must also understand that with foreign travel and globalization and the drug trafficking, we are not becoming, we are getting exposed, people are getting exposed to it as well. So across the cultures, we do get that influence. Then there's the concept of the cannabis amotivational syndrome. This was identified by some West African psychiatrists who know that people who've used cannabis for a very long time, they develop some sort of amotivation. The next big heading I want to refer to is genetics and family history. We know that if you, in the traditional sense, you're going to ask for someone's hand in marriage, the family sends scouts to the other and look out, this family is a history and other things. So, but there's a heritability in psychosis. Then another big topic is stigma and discrimination within families, within the person, and then societal, and even amongst professions, the health professions. Our own colleagues in general nursing or general medicine don't quite think that we are doctors, but we all have the same biomedical training. Now, another big domain are the disabilities that arise from having developed psychosis. I've already made reference to some of them, cognitive decline, neglect in personal hygiene, neglect in nutrition, early mortality. And these disabilities can be grouped short-term, long-term, and there's a role of rehabilitation, sometimes cognitive remediation, in bringing people back to where their pre-morbid levels of functioning. It's very important that with psychosis, by and large, people don't have an awareness of what is happening. And the carers and family members have equally got a role in its causation, perpetuation, and recovery. And one of the concepts is expressed emotion, the reaction of carers and the support of carers. All these things are very important domains. I'd like to focus a little bit on expressed emotion. And expressed emotion is like a characteristic of the family environment. And these are some of the things which characterize expressed emotion: over-involvement, emotional over-involvement, excessive critical comments, excessive concern, and sometimes negative comments and feelings, and then hostility. This generally captures it. So reaction of carers can be very varied, but one important thing that people need to contend with is the ideas of guilt. So I've sort of, in these few moments, rushed through, and I know my colleagues will be waiting to go deep into it. I know I'm a doctor, but I have specifically steered away from the use of medication to treat a variety of medications, which antipsychotics from the early 50s, and there are newer ones which have less side effects and equally effective. But it's important, the aspects that I've mentioned are things that have arisen out of experience and things that shouldn't really fall off the radar whilst we seek treatment in this country. Having said that, there are people who sometimes have decided to go back to Ghana and see psychiatrists practicing in Ghana and to go and see them. And they have a different spin in terms of their treatment. And they come back. I remember one consultant psychiatric colleague who said he had a patient. The patient went back to Ghana, came back, and was better, had recovered. I saw a Ghanaian psychiatrist and came back with a different sort of prescription. So our colleagues, our senior colleagues who taught us in medical school, trained in the UK, most of them trained in the UK, went back and applied what they learned to the Ghanaian context and have come out with some very rich material. So I'll end here, take a break, and let my other colleagues continue.
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.
Thank you so much, Dr. Doku. It's an interesting topic I've taken today and gone through a lot, so you have a lot of questions coming by the end of the day. Thank you very much, and we will move on to the next panelist. Our sister, Victoria Edu Annan, will be taking us through and focus more on child and adolescent mental health and early interventions. Sister Edu Annan has been in the mental health services for well over 25 years and held a variety of positions, currently working with the East London NHS Foundation Trust. So, Victoria, please take us through, and hopefully we'll have more to add to the questions when it comes round.
Okay. Good afternoon. Good evening, all. Can you hear me? If you can, Mr. Kwesi, can you hear me?
We can hear you, yes.
Okay. Thank you. First of all, I would like to extend my gratitude to the chair lady for Ghana Nurses Association for nominating me for this to host this program on behalf of GNA. So thank you very much. I also like to thank my colleagues from East London Foundation Trust. I know a few of them are on the show listening to me giving the talk. So thanks a lot. And also to Ghana Union. All right, I'll go straight into the topic. I was meant to share my slide, but I was having technical problems. So my slides will come later after the program. Right. When you talk about mental illness in teens, I would say it can start as early as some people. I've seen some young children starting having mental health breakdown as early as 8 years. But the most majority that we work with, some of them come into the system from as early as 10 years, some 11 years. And frequently it's been, the majority of them that we've been getting, they come in from 12 years, 12, 13, 14. That's the age that they start, the illness starts manifesting itself. Most of the time, I would say some of them have family history. So they either the mother, the father, or the grandparents, someone in the family would have the illness, and the child will end up having it or start to show signs of exhibiting it. That is one. There are other factors as well, like when they're exposed to extreme stress, they can start showing signs of depression. Some of them too, when they are exposed to taking drugs, then they can start showing signs. Others, when in terms of when we have, as some young children will come in with self-harming behaviors. We might also have some of them coming in when they've been assaulted at home in terms of rape or extreme bully. They would also start showing signs. It's not all of them who will come in needing medication. Some of them, when they come into the system, they are offered with therapy, talking therapy. The general person will say talking therapy, psychology. They will talk through it and then educate them on how to manage. But in our service, the younger ones, some of them, once they get into it and they get treated, they see the treatment that they receive within inpatient service, they become accustomed to it and they don't want to leave. Even when you offer them discharge, I noticed that a lot during the Christmas period, because they have all the luxuries that some they don't have at home. There are some too who have the luxuries at home, but they just say they don't get on with their families, so they don't want to be discharged home. Those those are some of the groups. Then I'm going to stress on the young ones who have psychosis within the family. Therefore, psychosis is manifesting in the early stages. Those ones, once they've been observed for 2 weeks and the presentation continues without changes, that's when they start treating them with some small amount of antipsychotic medication. When I say antipsychotic medication, some of them, they might be on a small dose of either risperidone or quetiapine. Sometimes, if they've been known, they might initiate clozapine, but it's very rare, very, very rare. But in the young people, most of the time they'll give them either risperidone, quetiapine, and misopride. All these new antipsychotic medication, they are given on small doses to monitor them. Some of them are given melatonin because they are not able to sleep, so they need to have that to help them to sleep, and also talking therapy, and they have education as well whilst on admission on site. So they continue in order for them not to have a disruption in their academic curriculum. They are given education, they have education on site whilst they are still sleeping, inpatient, sleeping on the ward. So they have all the systems in place, and they have sports therapists as well attached, so they can have physical activities. And then they have the youth, some of them helping them, young support workers helping them, coaching them and nurturing them, and then regular talking treatment to support them, and also to identify causative effect why they came into hospital. Parents are most of the time involved in their treatment, but from that point on, if the service identifies that once they are discharged, they keep coming back into the system, then we start looking at other supportive networks that we can do to support the young person. At that point, that's when my service will come in. So they would then invite me for professionals meeting, and then we will discuss the young person. We'll look at how best we can support them. If we feel that it's something that is going to be ongoing, then we step in at the age of 17.5. So say 17 years, 6 months, we will take over, but not fully. We'll be joint working with the inpatient team to ensure that the young person gets to know us, and then we also get to know the family. So as soon as they are discharged at age 18, then the early intervention service will come in. It's at that point that when we come in, we will look at all services, what has been happening, how best we can, because we want to support them to get treated in the community, at the same time for them to get on with their normal routine. Some of them, because they've had a lot of treatment in inpatient, or they spent a lot of time in inpatient, they tend to lose some of their normal community skills like shopping and other things. So we have to come in, support them. We have support workers and things who will go out with them, monitor, observe. We also link up with their school as well to make sure their education back in the community is uninterrupted. And at the same time, having the family, the father, the mother, brothers and sisters, we take them on board and start educating the whole family. At some point, when you are assessing these young people, they will tend to tell you that there's no one in the family with mental illness. But when you delve deep, you find out that there must be someone, for example, an auntie or someone. Those are the unique cases. Then you would also have some who are referred to the service straight from GP coming in, and GP will think it's mental illness. But when they come in, and the service providers, we assess them, we find out that there may be other things that is triggering the young person to behave like that. On those kind of unique or rare cases, we don't initiate medication. All that we do is we have a system called watch and brief. So we monitor them every week. We have contact with the young person and we build up a caseload. At times when you build up a case, so you see that the mental health of the young person is deteriorating over a period of time. As soon as we notice that, then we step in to either give them medication, to monitor, to see. At some point, when you give them medication and you educate them, they will keep taking it and they will get better. When they get better, we just continue the small dose and we advise them to continue to maybe 1 year. During that 1 year, if we feel that the young person is doing well, we will gradually reduce the medication, stop for 6 months and see if there will be any signs of relapse. If we notice there's no signs of relapse, then we totally stop the medication and ask GP to monitor them. That's another step that we use. If, on the other hand, we stop the medication and we identify that the young person is starting to show signs of relapse, quickly we go back to giving them, continuing the medication, and sometimes increase it a little bit and monitor. Sometimes these people, these groups of individuals, you can do that whilst they are at home. Others, they might need to go into admission. And from that point on, when they go into admission, treatment is intensified for them to get better. Then we have other groups of people, that the watch and brief groups, that when we monitor for 6 months and there is no signs of mental health breakdown, we just discharge. Sometimes they might need just talking therapy to support them to find out the causative, and also I advise them and the family on what to do or what to look out for so they don't become unwell again. Then we use other sources of support, like back in the saddle, which is a psychological therapy. So you sit down, discuss the problems, how to identify relapse indicators. At certain point in their life, some of them may have lost their jobs because their employer may not know that they are unwell. When it's like that, when we identify that this is what is happening to the young person, we step in. Sometimes we do ask families to, we do ask the employers that we hold a meeting with the employers, and then we tell them that, look, this is a vulnerable adult. You cannot just terminate their contract. They need to get back to work because they were unwell. And then we support that with a letter. That's for those working. Those in colleges, we do also link up with the school safeguarding team or the identified school lecturer. We do inform them that we have a young person in the college who has mental health needs, and we are the professionals involved with them. So if at any point in time the young person fails to complete their assignments or is not attending college, they should keep contact with our office, and that way the care coordinator or case manager steps in, have a meeting with the school and the young person, and request that they are given extra time for them to complete their coursework or their exams. And that is always a success story as well that we do. Other times too, the young person might not want the family involved. In those kind of instances, we do go the extra mile and explain to them the reason why it's important to have their families involved, so the family can also look out for signs and symptoms if they are becoming unwell. Those are some of the few things that we do. The list is ongoing, but I'm going to cut it short. Some of the things that as a parent or as a carer that we may have to look out for is in the young person to ensure that things are going smoothly, their life is going uninterrupted. Is when there is changes in the young person's sleep, new onset of guilt. For example, you know that your child very well. They are functioning very well, and then suddenly they start saying that they feel that they've done something wrong, and it's going on for a period of time. For example, 2-3 weeks, they keep saying the same thing. Then it's a warning sign that as a parent, you need to take your child to the GP for GP to also assess changes in their concentration or task completing. They find it difficult to complete basic tasks, because these are the little things that they will do to start giving the parent or the carer the prompt that something is not right with the young person. Changes in appetite could be an indicator as well that you may have to look out for. Changes in their motivation and thoughts of suicide. Sometimes some of these young person, there's suicidal tendencies in the family. So as they are maturing from 15, 16, 17 going, you start noticing these signs. So when you start noticing these signs, then it's a time for you to call for help for the young child before they act on their instincts or act on the prompts, the behaviors that are coming on. Your GP, normally when you see GP would have known the child's history, but he would gather collateral with the family, and quickly they would ask services to step in. So sometimes it's always a good initiative when GP steps in and then contact the mental health professionals, because the earlier we treat the symptoms, the better prognosis for the young person. So as a parent or as a carer, it's important that we study the young person, our children or our family member, and identify if things are not going right. Sometimes too, it's changes in hormones. It can make them very challenging and very disruptive. But as a parent, you need to monitor. And at times, it's the way that we talk to our young person, because once they get to that teen years, 16, 15, 14 years, they become very challenging. Then they have a lot of energy. So at times it helps when we also talk to them or engage with them in a positive way, but not in a confrontational way. Because when they come to the services, and we professionals, when we're working with them, we try to come to their level, not become so authoritative. That way they are able to open up and tell you the problems that they are having or the issues affecting them. At times it's through school, it could be bullying, it could be assignment, or could be for example, I came home one day and I noticed my young son, my second son, was quite emotional. So I did ask him, he wouldn't open up. So I went down to his level to ask him what was happening, not knowing one of his friends had died. So he was very emotional over a period of time. And then I had to talk through him and support him and ask him, if he wants to go to funeral, I'm happy to take time off work and go with him. You have to be there for them. You have to be their friend, but not always being authoritative in our Ghanaian way. I'll say Ghanaian way, because as a Ghanaian, I know when your parents are talking to you and you disagree, you are not allowed to talk back. Whereas in our Western way, yes, you can talk back, but in our African culture, parent, they find you to be a bit disrespectful. So sometimes we also need to change our ways in how we engage with our young ones. Warning signs of mental illness in teens. For most kids, one of the telltale signs is going to be a decline in grades, but for others, but there are other warning signs as well. Changes in social habits, including pulling away from school, friends and activities that your child has enjoyed participating in the past. It could be any other warning sign. Some of these could be generalized anxiety, social phobias, and depression have also had their own unique symptoms. Ways of managing, as I said, they can have talking therapy. They can also have psychotropic medication, that's the antipsychotic medications that will help to manage them. In my service, I did say we have watch and brief. where we monitor the young person for 6 months without any medication. But the case manager has weekly contact with this person, and also the family are also educated. So if there's any changes, the family will quickly contact the case manager. Case manager will go in. Sometimes with medics, we'll go to the house. Even with the COVID time, we're still doing that. In very rare cases, we were going into families' homes with full PPEs to observe and see how the child or the young person is behaving. And if they need admission, we quickly escalate for the young person to go into hospital. We also have one-to-one sessions with case manager to identify the cause of mental illness or the cause of the mental breakdown and offer treatment. And then we also have the coping strategy. We educate the family and the young person signs and symptoms of what to look for in terms of when they are becoming unwell. And we have peer support workers as well to support in the team that can support the young person. We also have what we call employment specialists. So if the young person wants to go to work rather than going to college or university, then the employment support specialists are there to help them build up their CVs, so they can also they are also linked with various employers, so that we can support them, escort them to go for their interviews and back, and then follow up. If they didn't perform, we follow up where they went wrong, and then the next interview we go with them again to make sure they get a job. Then we also have the few young people who are exposed to drugs and alcohol. Those ones do we have drugs and alcohol service attached. We also have the advocacy service, whereby they can also step in to educate and also support the young person. But of late, most of us are trained, so we can support the young person as much as possible rather than seeking the outside help. But the advocacy agencies are there, and we have Mind as well to help as well if they need the support. So I'll leave my session here, and then I'll hand over to my next colleague who can talk about it. Then following on from there, we will have questions and answers. Thank you.
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.
Thank you so much, Victoria. This is very deep. We've gained a lot from some of the things that we see around in our community, in our family and friends, and the nurses being close to the patients all the time actually demonstrated a lot. The doctors, yes, they come in, they give you all the identification, and then they pass it on. So you are our day-to-day contact when we find ourselves in this situation. So yes, I'm very glad that you've opened a lot of points that will drive others to actually bring some questions when it comes to the Q&A. This program, as always, put together with the help of Ghana Nurses Association, the Western Region Nurses Association, and the Nightingale Nurses Association, in partnership with Ghana Union. It's also supported by the Ghana High Commission and Omega Live TV. Let's not forget, as always, my job is to look out for the best deal you can to support the community. We are in a pandemic, people are struggling. So why don't you try Express Pay? Send some money through them. Let your family member in Ghana get extra £10 for whatever you send. It cannot go any bad. Let me also acknowledge the support and the participation of one of our sister groups and our affiliate groups in Ghana Union Halo. Ghana Union Halo have been supportive from day one. They are always on, and I can see their presence. So welcome and thank you for joining us. We will go to the next panelist, our sister Rose Humble, a divisional lead at mental health nurse, a divisional lead and mental health nurse with the Oxford NHS Foundation. Rose will focus on mental health management from medical and community perspective. So Rose is also currently the president of the Cameroonian Nurses Association. Rose, please, you're welcome and take over.
Thank you, and I hope you can all hear me. So
Yes,
good evening,
yes.
everybody, and thanks for having me. I'm going to start by just saying a few words of thanks to the Ghana chair, the Ghana Nurses chair. So Martha, thank you. I'm here today because she extended the invite, and also to say thanks to, I think, some Cameroonian nurses in the group watching. So thanks for joining us. So I'm going to be looking at some of the things that I'm going to say. You probably would have heard it from the last speakers. So I'm going to focus on the management of psychosis. I'm going to focus on the management of psychosis. So you've already heard about some of the definitions that Dr. Duku said about psychosis. So what do we know about psychosis? We know that it is a severe mental health problem which can extremely impair our ability to think clearly, respond appropriately to emotion, communicate effectively, understand reality, and behave in a way that is, in quote, normal to the normal society. We also know that psychosis occurs in several different mental illness, not just schizophrenia, but depression, bipolar disorders, and many others. And we also know that sometimes drug and alcohol misuse can produce some form of psychosis. It also occurs in a number of neurological conditions, which drugs are not associated to in terms of misuse. We know that psychosis interferes with the ability to function, and it can be very debilitating. It is very disabling, and we know that the disabling symptoms would include delusions and hallucination. How do we know about the symptoms? So Victoria have told you quite a bit about the symptoms for the young person, so the teenagers. So how do we know about it when we are worried if you've got a person or a relative or a loved one who you might think they're suffering from psychosis? So I think from a medical perspective, you'll be looking at the nature of the delusion or hallucination. You'll be looking at the time frame that whatever it is that you're worrying for had gone on. So the time span. You'll be also looking whether there is some recurring themes, and you'll be looking at whether there is an insight into being unreal. So from the person, has there been any major life event? We know that life events sometimes can produce trauma and people can react to it differently. As Victoria said before, is there a history of mental illness in the family? Has the person started using or abusing substance? Does the person, in terms of their behavior in the past, has it changed? Are they vulnerable psychologically? Are they irritable? So there are all the signs that you could actually take stock and just to monitor and watch. While you're taking this history and while you're concerned, you also need to think about whether there is loss of touch, so loss of reality, whether there's fluctuation in their moods or behavior. You need to think about their speech. How are they communicating? Is it clear? Is it disorganized? Is it abstract? Or is it vague? And has this continued over a period of time? What does their emotion look like? Is there confusion or excitement? Is there depression, or are they expressing something that sounds like, we talked about suicidal ideation. What are they? Are they safe for themselves or those that they live around them? So in terms of the management of it, so from a medical perspective, I'm not a doctor, I'm a nurse by background, but from a medical pathway, it is very important that you recognize and manage the first episode of psychosis correctly, so as to, any delay in diagnosis can actually have a very adverse effect on the prognosis. So time is really important. In the initial management of first episode of psychosis, your GP is quite crucial and is quite key to this role. So the GP's primary function at this point is to make a presumptive diagnosis and then arrange for secondary care assessment. So some of the discussion or some of the description that you've heard Victoria has given, most of those would come in what is called secondary care rather than primary care. Occasionally, the patient's behavior or the person's behavior will be such that as a parent or as a family, your safety, their safety, those that live in the house, their safety is at risk. So in those circumstances, you really need to link with the GP and try and get the appropriate advice from the GP. What's the aim of treatment? So for those people who develop psychosis, the aim of treatment is that we want to reduce the time between the appearance of the symptoms. So from the time that the person develops whatever symptom that you're describing as not their normal pattern, to actually initiating some kind of therapy that would help to treat the untreatable symptoms. We want to accelerate remissions. In other words, prevent relapse. In other words, ensure that they don't end up in hospital, just as you've heard from some of the two speakers. We want to use both biological and psychological measures. We want to maximize the person's ability to get back to normal life, so to get back to their optimum, how they used to be. And we also, in some cases, want to start with prompt assessment. Again, this is prompt clinical assessment or mental health assessment. Sometimes, unfortunately, hospital admission would be the first line to go because of the safety issues that might not be able to be contained at home. So in those cases, a psychiatric unit or hospital would be looked for, hopefully by the GP or somebody else in a psychiatric service. You try as much as possible to avoid compulsory detention. So some of you would have heard something that we in mental health would say the mental health act. So you try to ensure that you work with the person as much as possible so that if they have to go to hospital, they go in involuntarily rather than under compulsion. However, if they have to go in under a mental health act, again, all is not lost, because sometimes if you use compulsory admission, that therefore means that the person is then entitled to a very good legal framework, which therefore means that their rights and everything else and human dignity is preserved. What management is therefore available to us? You would have heard some of it already. There are talking therapies. So talking therapies generally helps you to understand your experience, and it helps you to develop coping mechanism to deal with whatever you're going through, so to deal with your symptoms. Now, there is something around men generally, or the male gender, generally they're not good in talking, so they're not very open with sometimes their words, particularly when they're in difficulties. And I also know that majority of the people in the audience, including myself and the speakers, we would be from ethnic minority backgrounds. So we also know how our men and brothers really find it difficult to talk. So other therapies that could be helpful, if talking therapy is not one that would be useful for them, is something like art therapy. So art therapy is a way that you can use to help you express your feelings and different ways of coping with your feeling. Victoria talked about family intervention. What is the focus of family intervention? Family intervention helps the family and the person who is experiencing the symptoms of psychosis to talk more about what is helpful, how can the problem be resolved, a plan for crisis. So particularly a plan that would help the person when they do go into crisis. Unfortunately, for psychosis, like many other mental health illness, there are no quick fix. So for example, in acute medicine, you might, I don't know, break your leg and it's easy to mend the leg. But when it comes to mental illness, it might, the sort of progress can be quite slow because it's quite complex and there is a lot of factors that comes into play. So from your genetics, your mood, your mental state, your family, your social circumstance, your network, jobs. So there's quite a lot of housing, there's quite a lot of things that can come into play. What other management or what other treatment is available? Early intervention teams. So the team that Victoria was describing does not only look at the age group from teen or almost adult to a younger adult, but it generally would look at early onset in adults. So those teams would actually be of help if you can be referred to them. There is the other bit that we call community care, which means for those people who are experiencing psychosis or have experienced psychosis for a longer period of time. If you remember, I said there are no quick fix in mental illness. So you would be referred or might be referred to community services, which will help you cope better. The phrase community care is used to describe a variety of services that is available to you to manage both your physical health and mental health problems in the community. You would hear a term that for those of us who work in psychiatry and mental health we generally use, which we call community mental health teams, or in abbreviation, they'll call it CMHT. So basically what that's describing is teams that are working in the community that are made up of psychologists, psychiatrists, nurses, occupational therapists, social workers, employment officers or staff who all help you and work with you so that you're able to function to your best. For yourself as a person who then experiences some form of psychosis, there are 5 self-help steps that you could take. At the time, it might be quite difficult because you probably will be experiencing, particularly if it's your first episode, you probably will be experiencing something which you haven't experienced before. Some of the things that would really be helpful with any illness is to think about whether there are peer support. So peer support basically just brings together those people who might have experienced something similar to what you're experiencing. So there are peer support, just as there's peer support in most physical illness out there in the community, i.e. stroke, diabetes, there are peer support also for mental health. So particularly for those people who have suffered with psychosis. So it's always good to try and make contact with those peer support, either nationally or locally. And some of this you can do through networks like Hearing Voices. You can do this through National Paranoia Network, Bipolar UK, or as somebody else in the past talked about, Mind. So Mind UK. The other thing that is crucial that you should try and do as a person who might be suffering with psychosis or having symptoms of psychosis or having a psychotic episode is just think about and try and recognize your triggers. So if you can, try and keep a diary. That might be helpful. Diary for maybe the triggers or the episodes or the symptoms that you're having. Diary of things that has just happened to you, i.e., is there any life event? Are you having changes in your mood? What does your diet look like? Is there lack of sleep? So try and keep those diary. You could do that by using a notebook, or these days we are all technology savvy. There are apps and there are tools that you could use online to keep a diary. Physical health is the third step, and it's really important to look after your physical health. Most of you, or some of you, would have heard those of us in mental health will say, there isn't any health without mental health. Equally, there isn't any mental health without physical health. So looking after your physical health so that your mental health stays stable is quite important. And how do you look after your physical health? Simple thing think about what you eat, having enough rest, having enough sleep, having a structured day, going out for walks or simple physical activities, staying in the green for fresh air is really helpful. Usually when some people, when they're faced with challenges in life, they tend to fall into bad habits, i.e., drinking a lot or using substance. If you can, it's good to avoid those. And the fifth thing, which is one of the most crucial things to do when you experience psychosis or you're suffering with symptoms that looks like or feels like psychotic episode, is create what we call crisis plan. A crisis plan is usually a plan that is done when you're not in crisis, and the plan that is done to help you when you're in crisis. What that means is do a plan with those people who care about you, so your families, those people who are involved with you, and the clinicians. So do a plan that then helps you so that when you're in crisis, people know exactly what to do. Now, doing the plan is not the main thing. Doing the plan, and actually that plan is then shared among those people who will care for you, including your family, would be quite important. Friends and family, on the other hand, how do they support? How can you support, if you're a friend or a family, support somebody who has got an episode of psychosis or who is experiencing psychosis? Again, most of us are from an ethnic minority background. Victoria did say sometimes we all know that some of us we've been brought up to always obey what the elder person says, or what your mom say, or what your dad say, and junior people or younger people can't say something contrary to what their elders are telling them. So as a family member or as a friend, one of the best things you could do is just listen. Listen to the person who is experiencing the symptoms or the episode of psychosis. Just listen and try and understand from their shoes and from their perspective. It can help if your loved one feels that they're able to discuss their feelings and options with you, because that means there is an element of trust. So when clinicians that they don't know are involved in their care, you can be that person that advocates for your loved one. The second thing that it will be really helpful for you to do as a friend or a family member is that focus on the feelings rather than the experience. What do I mean by that? So instead of, again, what we've just said is that sometimes if somebody is going through a psychotic episode, their reality of the world and interpretation of the world is completely abstract. So it's very different. So the way they see the world is through a lens that you don't see it that way. So there isn't any point if somebody, for example, I'm going through some form of psychosis and I'm telling you that I'm related to the queen or I'm white. As my mother, there is no point you saying to me, no, Rose, don't be silly. You're black, you can't be white, because I'm the one experiencing that. So go with the feelings rather than what I'm saying, for example. Again, there's no point denying what I'm going through. Instead, it would be better for you to say something as simple as, I understand what you're saying, the things that you're saying. I understand the way you see things because you're the one experiencing this, but it is not like that to me as an outsider. Offer practical help. For example, the person might want to access services and don't know where to start. So you're there as a helper to actually act on their behalf as an advocate, regardless of whether you're their mom, their father, their husband, their sister, their brother. You act on their behalf. Respect their wishes. Again, it goes back to some of the points that I've already mentioned about listen and try and understand the person from their own perspective, not yours. How do we then respect their wishes? Most of us, again, from an ethnic minority background, our elders know better than us. In the Western world, it's completely different. So even though whatever the person's wish might not seem or look normal to you, and you feel that you know what is best for them, you would have to as an adult, you would have to respect their wishes. Because if you don't, what that does is that it creates tension and you push them away and they withdraw and they then look outside for alternatives. So please respect their wishes. I've already talked about family intervention. Family intervention. At the beginning, it might all look very strange. Family intervention that is sought professionally would really be helpful. But also, we have the joy of having a good family network. We also have the joy of having friends or neighbors or people that either we've grown up with or gone to school with. Please do not close up. And know that in an African society particularly, mental illness sometimes is stigma, even nationally, worldwide, there's too much stigma around mental illness. So people don't open up. They don't open up and they tend to close things down. When you suffer with psychosis or have somebody who is suffering with psychosis, it is not an opportunity or a time for you to shut down. It's a time for you to reach out to so many people around you that will be willing to help. And as a caregiver, either a mom, a dad, a sister, a brother, a husband, a child, you need to get support for yourself. So you need to be able to look after yourself very well so that you can then give support to the person who is unwell. So finding the right support locally and nationally would be really helpful. So please don't be shy in asking for support. There is absolutely nothing wrong in asking for support. So please pick up the courage, whether it's support from those of us who are Christians, from your churches, your priests, locally, from council, from your GP. Please ask for support. There is ample support there for yourself as a caregiver. And there are important contact links. The first one being your GP. You've heard about Minds a lot. So there is Minds helpline, which provides you information for support both over the phone and by email. Each area has got a local mine service that would offer face-to-face and ongoing services across England and Wales. There is the Bipolar UK network. I've talked about Hearing Voices network. I talked about for the person who is experiencing the psychosis or going through that episode, it's good to keep a mood diary. There are apps. There is an organization which is all around mood diaries. So you can actually download them and try the tools that will help you to be able to keep your mood. And then, of course, there's the National Institute for Health and Care and Excellence, NICE, which most of you would have come across. There's ample information and resources in their network. And then there's the National Paranoid Network, which all, of course, can be found from any NHS site or NHS England site. So that is the end of my talk. And I'm going to open it now up for the question and answer sessions.
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.
Thank you, Rose. Tonight we've had the privilege of having experts from, if we can put them all on the screen, please, so that when we go to Q&A, people will know them. We've had these experts who have lived through, worked through these situation scenarios. They've been trained, they've been there, they've done it, they've encouraged, they've helped, and they've offered us the knowledge that we so much need. Some of us probably are sitting with family members, from children to adults, who have become very challenging, have become very difficult to manage from our African background or our community perspective. We almost write them off from our head. So it's actually very knowledgeable to know some of these information you've given us. Thank you so much, Rose. Thank you, Dr. Doku. Thank you, Victoria, for the time you've been with us. We are going to open the Q&A session. I will just say that, audience, please use your Zoom icon and raise your hand so that I'll be calling you. We still have some advanced questions here that I'll be going through, and I'll be coordinating the advanced question with those who have raised your hand. So I'll certainly call you. This program, as I said earlier, without the help of these key organizations, the Ghana Nurses Associations, their executives and members, the Nightingale Nurses Association, their members and executives, the Ghana Union in partnership with these groups, and of course, the Western Region Association of Nurses coming together and putting this together. We've been doing this since February. We want to keep going. And all I will say is encourage your friends. When you hear this flyer going around or you see it, please make sure you invite others to join. There are very good information we are passing on to our community. Thank you so much. Now, we have some questions. The first question, if I may, we'll ask is, somebody wants to know what are the current statistics of psychosis among the Black and ethnic minority group community? Do you have any indication of how many of us are now put down or recorded as having psychosis one way or the other in any form or shape? Any of you can, please, if you have the information or some indication, even if you don't have the exact numbers, probably you can highlight on it from your knowledge and experience. And then
I'm just going to start, and then, I don't know, pass it to the other two. So Dr. Doku might be able to answer this. Haven't got the statistic off head, but there are statistics to show. But again, it would also vary from region to region. For example, I worked in South London and Maudsley NHS Foundation Trust for over 20 years. And when you look at the sort of diagnosis and the geographical area and the population, there were more ethnic minority patients with that trust and the London Trust who either has got a form of diagnosis around psychosis or schizophrenia. I'm currently down now in Oxford, and when you look at the geographical area again, there's a difference, which means the 80% of the people that I work with where I am now, or the services that I run, 80% of the people that are down that area are white, are from a white background. So again, the diagnosis there would be different. But I think nationally, there is a percentage. And I don't know whether Dr. Doku, you know what the percentage looks like nationally.
Yes. So can you hear me?
Yes, we can.
Yes. So by the time the hospital statistics sort of differ from what you do in the population. So hospital statistics are skewed towards the very severe people. So really, what we should be looking at is surveys within the community, and generally compared to the last presentation, anxiety and depression, psychosis is very rare. We're talking about 1% of the population. But in terms of health, help-seeking behavior, etc., the people in the catchment area were previously referred to. There are deep suspicions in terms of the health service. So they are not likely to go to hospital until it's very late and until the symptoms accumulate, and therefore we tend to have a bias in terms of the severity, and that is followed on in other sectors in terms of forensic arrest by police and all that. There's some inherent mistrust. Yeah, but generally psychosis is generally thought to be rare in the general population compared to depression and anxiety. You're talking about around incidence of around 1%.
Thank you very much. Thank you. I'll go to the audience and call one person. I'll be coordinating from what I have and from the audience. I have Sam Okori. Would you please unmute yourself and ask your question, please? Sam Okori.
Can you hear me?
Yes.
We can.
Oh, thank you very much. I wish this forum could have happened in the 80s. In short, my question is to everybody who is listening and also the panel members. Dr. Doku made mention of the causative, the sources of this cancer in our society. And I think we find ourselves in an environment which is probably against us. I'm talking about tradition and Western medicine. There was a doctor, I think he's a Nigerian, Dr. Lambo. He set up a village to treat people which we are dealing with in this country as mental health nurses. Our tradition and mores, probably when you compare it to the Western world, they do not go hand in hand with what we find ourselves here. For example, when we were being trained, so many of us were put down as probably we were not well in the mind because of simple things like exchanging eye contact. We were put down. There are so many issues, but I wouldn't go into so much. The issue is that we have our own tradition. For example, Beye, speaking in tongues when you come to religion, to faith, it's only of late that some corners on the walls are created for faith. People can go in there and probably to pray. But in those years gone by, if you mention Christ, if you mention things that are not in conformity with something which you can measure, you are termed as not being well. We are in summer. Those days, maybe it's still going on, but those days, if you see Afro-Caribbean Black person shouting and screaming and so on, it comes to a point that a police is called and immediately the person is sectioned under 136. These are all issues that is going against us. I'll cut it short and ask the question, what are we doing, especially the panel members, about traditional and Western medicine in terms of psychiatry or mental health?
Thank you very much. Any panelists can take from here. May I just say that we've only got 30 minutes and I want as many as possible to go through. So thank you so much for your contribution and eventually the question. But if we can all be brief and straight to the point, okay. We have enough questions to go through. Victoria, please.
Okay. Sam, thanks for your question. Well done for bringing such a topic up. In my service, I'm going to say my service because I don't know what other areas is, but I believe they will be emulating the same. We do encourage religion as well. So you can still merge religion with treatment, because if they are Muslims, we do have imams on sites that they can go to. We do have faith. If you're Christian, we do have religious officers around that they can contact to support them with their religion, and at the same time they have treatment. So they cannot, because most people, they will come into service and they'll say, for example, in the African culture, they'll say, be like that. So we say, okay, if that's the case, we have the faith pastors. We have some that we even link with the pastors. They can still go to the church or go to the imam for their prayers, and vice versa, they will come to us for treatment, and we work hand in hand. So that should not be a problem. They can still have both sides of the coin to get them well and back to how they were pre-morbid personality. Okay.
If I may come in, so Sam does refer to a very historical system of treatment pioneered by Professor Adeoye T. Lambo. And it was based in Aro village, Abeokuta, in Western Nigeria, I think, yeah. And it's there, you would see Western trained psychiatrists, but your family come and live with you, and you live in small sort of compounds with your family with you. You cook the way you cook, you know, so it wasn't using like a Western accommodation facility, like you have wards and etc. And they found one of the findings was that the outcome, because of the family involvement, was much better, and people recovered much better, and they were given treatment nearer their homes and closer to their family. So that is very important. And now, in terms of the culture that you mentioned, there's a lot of cultural clashes in terms of moving from developing countries here and what we experience. And I think both my colleagues have expressed all the differences or the ways in which culture influences not only the manifestation of symptoms, but also the treatment. And it's important that people are not devalued because they believe in certain things, but that's their belief system. They come with that, and a holistic service needs to, even though it's Western, based in a Western culture, needs to acknowledge that aspect is very important. You could see from my presentation that I gave a little bit of prominence to that, because we have come from a different setting, and it's our children and etc. who are adjusting to this cultural environment and experiencing this. So those cultural factors are very important.
Thank you very much, Dr. Doku. I have Kofi Agbelegbe. Kofi, please unmute yourself. If you can unmute yourself and ask your question, please. Kofi. Is Kofi with us? Shall I move on to Irene B? I hope.
Kofi is with
Hello.
us. Yeah.
Oh,
Hello.
okay.
Yeah. Oh, thank you very much for giving us this opportunity. I'm quite impressed. The question Sam raised, I think is a key one. And I just want to know what the current diagnostic criteria are. I say this because in some of the settings, our behavior, when I say our, African behavior, normal behavior patterns are pathologized. And so somebody who on the ward is pouring libation or going through the process of libation is defined as being highly psychotic. And they then start them on antipsychotic medications. And the side effects make the person ill, when in actual fact, what they're practicing is what most African cultures practice as a normal behavior for people who are going through stress. Can you just elucidate this for us a bit as to what the diagnostic criteria these days are in terms of transcultural elements and how they might mask a normal behavior?
I think if I could just say something, Dr. Daku, I could see you're coming into this one because I'm sure it's under your field diagnosis. I think thanks for the two last Kofi and Sam for the question. I think what I'm getting, what you're describing, sounds like what we all know. It is true that Black and ethnic minority people are highly represented in mental health. So majority of the people who are sectioned are from ethnic, and they're highly overrepresented. And it's possible that it could be as a result of either high diagnosis or some type of diagnosis. So you are right that there is inequality in terms of the overrepresentation of Black and ethnic minority people in mental health services. So with regards to the diagnosis, I'll pass you over to Dr. Daku to just give you the criteria for the diagnosis.
Okay, so what I would say is that in this country, we use the International Classification of Diseases, ICD-10. It's now, the new version is, I think, has been published, the ICD-11. Now, the field trials that led to the development of these criteria occurred in all over the world internationally. So they went to UK-trained psychiatrists who've worked in Africa, Ghana for a long time, and all their views were incorporated. So in terms of the diagnostic criteria, I think the ICD-10 is internationally valid because of the field trials and the representation. So in terms of the description of what we have, and I'm talking about those who taught us in medical school, they are trained in the early 80s here, and they returned. The likes of Lambo and etc. They really applied themselves to the culture, and so that if an African psychiatrist was making a diagnosis, they wouldn't really overdiagnose, because it was the context of their practice gave the meaning to it. And you recall from my slide, I mentioned subculturally influenced ideas. So it's very important that the diagnosis is situated in one's culture. Unfortunately, if people don't understand people's cultures, then they are likely to overdiagnose because of maybe their lack of cultural competence. So we know that there are lots of initiatives now to improve people's cultural competencies, not only about West Africans, people from the Asian subcontinent, and etc. And we do have to consult extensively around that.
And Dr. Doku, to add on to that, we do also involve a lot of the language shop, so that they can also support us in assessments and all that, so that we know that we are going on the right path and in working in partnership with the patient and the families.
Yeah.
Okay. I have an email that just come through, and I'm going to just read it briefly from somebody. It says, please, what advice would you give to a relative concerned about her brother who moved from Sweden just before COVID to resettle in London because he felt there were people in Sweden who were after him. He's moved to a couple of places whilst in London because people are still after him. This is affecting him as he's not coming out of his room and he used to struggle to go to work. He's refusing to see a GP because he's convinced people are real and there are nothing they can do other than those who are constantly chasing him from his life. I will kindly appreciate if you can advise or give your views as how best we can approach this family. So basically, a family member who lives in Sweden has resettled in London because he thought while in Sweden there were people after his life. Whether physical, spiritual, or not, I am not sure. But obviously, this is from whatever you have said earlier. It's obvious signs that the person is going through some episode here and there. So, what advice he's not going to work? He's staying in the room, not engaging with anyone. In his head, somebody is after his life, even though nobody can see anybody around him. What advice would you give?
One of the things I'll say is, please, GPs can always go out. So the GP can actually come to you and see that person. So request for a GP visit. The key thing is try to get the person, because they're not going to accept help. They're not going, just in case something is wrong with them. You need to try and get help to them. So the key is to get them for an assessment and get a clinician to be able to do that. So your GP is your first contact. That would be my advice.
Can I also add on to it that it would be better if the family member can also give a little bit of a little bit of an synopsis. If the family member was involved with a psychiatrist in Sweden before they came to UK, that can also help a bit.
Right. Okay. But that leads me to asking, when you find yourself in a situation where your GP turn around and say, "You're not my patient. I mean, I can't deal with it. He's an adult. He's old enough." I mean, there are times where you wish you can call a GP, or how do you progress with that? Because the system is designed in such a way that once you reach certain age, you cannot really access somebody's private, confidential information in certain aspects. How do you approach that?
I suppose in mental health is slightly different, isn't it? So if somebody is becoming unwell or there's change in their pattern, their behavior, their routine, whatever it may be, what you're then looking at whether the risk of that person deteriorating in terms of their mental state and becoming worse. So the role of a GP in that case is to make an assessment. So you then contact the GP on behalf of that person and explain very clearly what your worries are. Because particularly when it comes to mental health, it's not like physical health where you could literally carry the person to go and see the GP or to go and see if a psychiatrist or anyone. So the person, the GP, you need to actually explain to the GP what the issues are and where you're concerned. Failing GPs, you've got also social workers in the community. So the person might be an adult, yes, but they might be a vulnerable person. And the council would have a helpline in terms of when an adult is in crisis, how to get hold of social workers. So those are the other routes that you could use, even though the person is an adult.
Right.
The family member can also contact, if all fails, they can also contact the crisis line. It's a 24-hour crisis line. You give a background information, they'll keep an activity log of what is happening, and then they can escalate things. Because as you call them often, they can also support you to call the police, and the police can go in and bring the patient into hospital, regardless whether they have a GP or not. Once they get into hospital, they will identify a GP.
So the crisis line that Victoria is referring to, other areas they call mental health helpline rather than crisis line. So with COVID, there was the mental health emergency lines that were set up, and you get those through 111.
Right.
Yeah.
We shouldn't also forget that you can also go to accident and emergency.
Yeah.
You can go to A&E. It's very important. And for many people, they may have some somatic symptoms, and you could say, look, why not? Let's go to A&E and see what can be done. And when that is picked up, there are psychiatric liaison nurses working in A&E, and often things can be escalated that way as well. If what is the mention was made of risk, and I think the person here involved is already acting on the delusional thoughts by traveling actively, and now actively self-isolating or self-withdrawal. So I think we are getting to a crisis here.
Crisis phase.
Yeah. So I think a walk through A&E, mention what is happening. Psychiatric liaison nurses will be called to assess, and that will also be another route. Yeah.
Can I call on Irene B, please? Irene, if you can unmute and ask the question, please.
Yeah, thank you very much. I think this is sort of a contribution, actually. When Victoria was speaking, delivering her session, she did mention that her team would help if patients recover and have to return to work. Sometimes, because they've been through that situation, when they return to work, they are not able to do the job that they were doing previously. However, there is still help available. If the condition has lasted for more than a year or is likely to last longer than a certain period, it comes under the disability section of the Equality Act. And in my area of work, what we do is we would offer something called redeployment. So if they are not able to do job A, we would redeploy them to do something else that they would be capable and comfortable to do. So there is that available as well. Because what I find is sometimes people are reluctant to come because they feel that they can't do the job that they used to do. However, because these conditions usually come under the disability section of the Equality Act, the employer should do everything they can to help. So as I said, this is just a contribution to it.
Thank you.
Thank you very much. Thank you, Irene. That leads me to asking the question that came in earlier. Can psychosis cause brain damage? And at what stage can psychosis become be diagnosed to become a permanent disability?
So if we look at the MRI scans, the structural scans, magnetic resonance image scans of the brain. The majority will tell you about structural abnormalities, but they are the magnetic resonance spectroscopy. So what is now quite well known is that by the time you start manifesting psychotic symptoms, between 4 to 6 weeks ahead of that, there's already some brain damage going on. Okay, at the chemistry level, at the biochemistry level. So that's why it's very, very important. Someone mentioned early warning signs and preventing the relapse of psychosis. And it's been shown that these newer medications, olanzapine, risperidone, aripiprazole, they have a neuroprotective effect. So not only will they treat a psychotic episode, but they prevent you from getting a relapse, and they have got a neuroprotective effect. So the brain damage, while it might not be structural, occurs at the biochemical level, and is very well known. So,
Right. Hello?
I think
Dr. Doku's line. Yeah.
Have a long-term type of psychosis after having episodes and remission. So the psychosis goes away, it comes again, goes away. For about a third of people, they just experience one psychotic episode and nothing else. But for others, for about another third, and the outlook for them isn't that quite good. And before the advent of psychiatric antipsychotic medication, those people had what was called, the French call it démence précoce, or dementia précox in German. It's like you've had dementia at a very early age because of the cognitive impairment. The advent of antipsychotics have led to a better outcome, but for about a third of people, it's a bit difficult, really. And these are the people who, in the former dispensation, you find them in psychiatric hospitals as long-stay patients.
And I suppose to add to all what Dr. Doku has just said, if in my presentation, one of the things that I said was, it is a combination of factors. So it's quite complex in the sense that it is a combination of factors that might cause you suffer with any form of mental illness or not. And some of that from a social context, things like housing, the economy, your work. So all those things are not static. So because they're not static, it therefore means that your stressful and what stresses you up or what leads to breakdown is going to constantly be there. There are times where I'm sure my other two colleagues will know, at work, you hear people say, okay, if you could take all the social context out of that person's life, they will get better. But because that social stress, lack of housing, poor housing, lack of income, all the various other things that we deal with on day to day, majority of the society, it does nothing. But some people have got that vulnerability aspect. And because those aspects are still there, it means it's an ongoing illness that, just like diabetes and high blood pressure, that you need to be on some form of therapy or medication to keep it maintained. I mean, there are people with psychotic, suffering from psychosis or schizophrenia who hold down the high-flying jobs.
Yes.
And they maintain that. So I think it's worth noticing that in as much as it might sound challenging and difficult, many people hold down good jobs who have got mental health problems. If you know the statistics, that 1 in 3 or 1 in 4 would suffer with mental health problems, even though it might not be an enduring, mental health problems, but it's there. And once we know how to manage it, we can manage it just as we manage any other physical health problems.
Okay, thank you. We had somebody's hand up that has put it down, but I wondered if the person still have something to. Vida Otin Ajiman, do you still have your question or it's been answered so that I can move to someone else? Vida Otin Ajiman, if you are with us.
Oh, yes, thank you. I would say a very big thank you to our panelists. They've really done very well. I just wanted to say something about the crisis, when people are in crisis. We recently, depending on the locality, there's been recent services who are called Crisis Assessment Team, the Mobile Crisis Assessment Team. And they literally go to people's houses to do assessment. And so that is something that might be considered if the person is reluctant to go to the GP or go to A&E. I think the families are well involved. Some people might show the high emotional expression and all that, but they do tend to do their best to support their relatives. But if there are no avenues, then it does become very stressful for them as well. So I think that crisis team helps. Going into people's home helps. Thank you.
I think just a word of caution, Vida. The crisis services, the way they're commissioned, they're not all of them will take open referrals. So most of them will get referrals from another healthcare professional. So the person has to have gone to their GP or another healthcare, another social care or healthcare professionals for them to accept the referral because of the way they're commissioned.
Yes.
So it won't be across. So just bear that, just a word of caution. It won't be across everywhere. Definitely, most of our London trusts will take open referrals. But when you start going out of London, the commissioning is very different. So we just need to be careful. Yeah.
Thank you very
Yeah, Mr. Question, I just want to make a little point here about the importance of having a thorough physical, biological checkup, right? Because especially in the initial stages, because there are a number of physical conditions that can mimic psychosis, and therefore, your thyroid function, your liver function, your vitamin levels, thorough physical examination, thorough neurological examination, a scan of the head, and sometimes a test for epilepsy. Some forms of epilepsy can mimic psychosis. So and that is where the doctors come in, especially in the initial stages, to make sure that the physical health side is not neglected and thorough work is done at that side. And if you detect any treatable condition, you institute those treatments very early, and then you wait for the fallout or how the process will emanate. So it's very, very important. And sometimes withdrawing from alcohol, withdrawing from other drugs like diazepam, all those things can give you a form of delirium, or you may get an infection. In Ghana, we call it high fever, they're having, acute febrile illness, and that may present as psychosis. All those things need to be eliminated, and very comfortably and confidently, so that somebody doesn't die from things that are amenable to physical treatment. So I just wanted to mention that as an important pathway in the management. Yeah.
Okay, thank you so much, Doctor. I'm going to go through a chart that came earlier. A child of 15 who has gone through bullying, changed schools, but things have not improved. Instead, he has become more distressed. Has a change in diet where he is eating once a day. We are finding that he has less energy, and we are tired and become very tired every day doing activities. He sleeps most of the time during the day and night. He has become agoraphobic and are now not attending school sometimes at all. We are experiencing anxiety and fear and have been observed as chaotic in presentation, angry and directing anger towards a parent. The parent is distressed and needs the peace of mind to be able to do their work in mental health area and finding it difficult to understand what is happening to the child. What are the solutions available to help a child going through this? Will life become normal again, or will they need support with everyday life? The parent has contacted CAMS groups. So I'm not sure whether it's a question or a contribution or something you can elaborate on. It's obviously a family going through a situation with a child of 15.
Can I
That's
contribute?
Victoria. Yeah.
Okay. From what I've read the statement already on the platform. Thank you for asking this question. It's possible the child is going through some form of breakdown. The parent is saying they've counted CAMS. They should escalate it. I will say escalate, stress on it, so that they will send someone out to see them. It's possible the child might need a brief time of admission so that the parents can have a rest, a break, to be able to support the child. Depending on where they are living, if I have an idea, if they are in London, they will get an urgent admission. And sometimes they have a family room as well, where the parent can stay next door for the initial stage, depending on how far they have to travel, so that they can be there. The child, for at least for the first 2 to 3 days, at least the child should have an admission for them to do a thorough assessment and support. It's possible that at this stage that the information that I'm looking at, the child is breaking down at a fast rate. So the child might need admission. The parents should keep contacting the CAMS services, depending on where they live, and then they would get the support that they need. Yeah.
But just also to add, thanks, Victoria, just also to add that the school has got a part to play. There are quite a lot of camp services that enrich in the school. I know Victoria has spoken about the child can get an admission. Now, the way camps admissions are controlled, they're controlled and managed by NHS England. So it's quite challenging actually, and people can wait for beds, whether you're in London or out of London for a period of time. So I think about what the school can do, because there would be camp services going into school, particularly during this period of COVID and since the birth of COVID. So I think try the school, again, you could take the child, if the child is willing, you could actually take them and present to an A&E department. And from there, you have PITs, so liaison PITs, so CAMS liaison would be in there to assess the child. So there are ways that you could just keep going. It is going to be tricky because CAMS beds, they're far and in between.
Yeah.
And unfortunately, there might not be a local bed where you live.
That's why I was saying, if there's no local bed, because in my locality, that's why I was asking where they are coming from. There is a family room. So depending on how far they are traveling, they can have a family room where the mother can stay or the father can stay, just to reassure the child. And then when the child gets in, they can move on.
Okay, I have one or two other questions to ask, but before I do, I would just want to say that in 2 weeks, exactly from today, we'll be having another session, and it will be all about those who are concerned about the vaccine. Now that we are moving downwards to the age of young adults of 30 and over, some people have still got concerns. And also those who are planning to travel to Ghana for summer and to Sierra Leone, Cameroon, any other country, we want to do one-off session where it will purely be question and answer sessions, all about travel. What you need to know, traveling from UK back to UK to Ghana or to your destination, what traffic light system apply, what tests you need, what documents you need. So please take a note. 25th of June, we will be holding another one that will talk about vaccines, question and answers, and travel, what you need to know when you return and on your way out. So the next question I will be asking, we've got a few minutes to go. From your experience, somebody wants to know, is psychosis the worst form of mental health illness in your kind of category of area of work? Would you say psychosis is one of the worst or the worst of all that you? And if not,
I think that's difficult to say. Again, for me personally, my experience, I think psychosis is easier to work with because it's better managed if you know what you're doing. I think where the difficulty is where somebody then have dual diagnosis, so i.e. they're suffering with psychosis, and there is some additional bit around substance misuse, alcohol abuse. So when you start, and then they might then have underlying physical health conditions. So that's where it becomes quite complex. But for me, in my experience, plain is very difficult these days. I'm sure my two colleagues will say, to see pure psychosis. Hence the reason why when Dr. Daku was talking about the percentage of people diagnosed with psychosis, how low it is. If it's pure psychosis, I think for me, my experience is that it's easy to work with and manage. But if it's not, and it's got multiple strands to it, that's where the difficulties then begins.
Okay.
The challenge is that people don't have insights. You see, that's the real difficulty. So they're not aware. They may have some partial awareness, but not fully aware of what they are doing. They're not totally in control of their faculties, and that really raises the risk. I don't want to make sweeping generalizations. And for some who have the amotivational syndrome, the negative symptoms, that's also very difficult to motivate. Lack of hygiene, lack of grooming, social withdrawal, not interacting. So those aspects also, can be quite enduring and quite challenging. People who don't understand will say, oh, they're lazy. They're not really. They just they become apathetic. and it can become quite challenging for families as well. So amongst the family of conditions that you get, it's one of the most serious, I would say, and it will require some. That's why the early intervention teams are there, so that identified early and treated quite vigorously.
Okay. The last one I have here, I'm not sure if it's a question or something that you can explore within yourself. It says, my sister have 2 children. After having the second one, her attitude towards the other one completely has changed and always keeps saying, the second one is my angel, the other one is just a troublemaker in my life. In that context, what do you see happening here? Is it postnet, I don't know. Please, I don't want to say something that doesn't sit well. But if you can look at such a situation where a mother has 2 children, and then all of a sudden attitude towards the other one completely changed, and then the new one is only angel, the other one becomes a devil, even though the child hasn't done anything wrong, and then keep referring to the other one as you are a troublemaker in my life, and it's like as if regret having that one. What is going on here?
Can I
Yes.
add on? Can I just chip in before Dr. Doku goes in? What's the age difference between the children?
Didn't mention it actually, but it seems like they wouldn't be 2 old children.
So maybe the older one is just exploring and becoming a bit more mischievous or challenging.
Yes.
Doesn't mean that that child has psychosis.
Right.
So it could be that the child is being themselves, and the younger one might be much more what's the right word to use? More obedient. So whatever the mother says, the younger one does. But as children are growing, they become challenging. It's up to us parents to nurture them and also to guide them. So you can't just stay, because this one is a bit challenging in psychosis, you need to look at other areas as well. You can't
But
just...
also, Victoria, I think we don't need to medicalize everything. So
Exactly.
the sister needs to engage with the sister to try and understand why the first child is whatever it is that she's describing. What are the challenges that she's seeing from that child who she's describing as, the bad child? So it doesn't have to be anything abnormal or mental illness. Again, it depends on when, I think Victoria was asking the age to try and establish whether it's, within the last 2 years or something. Postnatal depression doesn't come after somebody is 15. So it just depends on,
Yes.
the age. So there's a lot of, things that we're not sure. My caution would be that the sister should not try and medicalize it first. They should try and explore with her sister what the issues are. And it could just be parenting skills.
And perinatal, that's why the age will determine the age differences and the age of the younger child. It will there's so many factors that we have to look at.
You would also recall that I mentioned premorbid personality or personality.
Yes.
Same parents, different temperaments, and each one requires have their unique needs and need to be treated specially. Everyone is different, really. So you don't, as we've heard, you don't really have to pathologize it.
Okay. So that is all time will allow us to go on. At this point, what would I say? We are very grateful to you, Dr. Doku. We are very grateful to you for your time and all the efforts coming and on 2 occasions. Rose, we are so grateful for the time, the knowledge and experience you brought to bear, and our sister as well, Victoria. You've brought so much knowledge and experience to this discussion. We can only be thankful. The community is indebted to all of you for the good skill you brought and the knowledge that you've come to share. We will continue to call on you, and we hope you will avail your knowledge and expertise to our services for the good of our whole entire Black ethnic minority communities. Thank you very, very much, and I wish you well, and we will continue to seek your support. On this note, we want to thank our sponsors, Express Pay, those who have come on board, all our audience for staying through with us. We know there is football going on, but most of you managed to stay all through. next time. These are health issues, and we want to make sure you can get as many people to join us. So until then, we want to thank Ghana Nurses Association for their partnership, the Nightingale Nurses Association, Ghana Union, and Western Region Association of Nurses, and also our audience and the group called Ghana Union Halo, who are watching all over from wherever they are, and their members. We want to thank all community groups for joining, individuals for joining, and until then, again, we wish you all a very good evening and a good night. Thank you very much.
Thank you.
Thank you.
Bye. Two to go.
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.